come inside, there's not going to be a barrier left. So not just one particle, but all of gliadin food that you're taking, you're definitely going to have weight loss. Apart from that, these people will have they have a correlation. So the risk factors are people who already have type 1 diabetes. Hello everyone, welcome back to Tutor series. My name is Shujauddin, and in today's session we're going to be talking about celiac disease. So before we go into the whole pathophysiology and what happens in celiac disease, let's just look at the few facts that we have in celiac disease. So firstly, celiac disease affects your small intestine. Like if small intestine has duodenum, jejunum and ileum. So especially if we were to look at the small intestine, it's going to affect your duodenum mainly, then your jejunum. So celiac disease is going to affect your small intestine. Secondly, it is associated with HLA, DQ2 and DQ8. So people who have human leukocyte antigen DQ2 and DQ8, they are at a higher risk of having celiac disease. Thirdly, celiac disease has a gluten hypersensitivity, and that gluten hypersensitivity turns into an autoimmune condition. So celiac disease is an autoimmune condition as well, and it has gluten hypersensitivity in it. It affects your small intestine, and the whole damage that causes celiac disease is mediated by two things. First one, your CD4 T helper cells. Secondly, it's your IgA, that is immunoglobulin A. They are going to mediate the whole damage. Now, you would remember that you have four kinds of hypersensitivities: type 1, 2, 3 and 4. Type 4 hypersensitivity is that hypersensitivity in which the whole damage is mediated by CD4 cells. And I just said that the whole damage in celiac disease is mediated by what? It's mediated by CD4 cells and immunoglobulin A. Hence, celiac disease comes under the heading of type 4 hypersensitivity. So yeah, let's just go over it. I have written this down here. It has an association with HLA, DQ2 and DQ8. It is an autoimmune condition in which and it is due to gluten hypersensitivity. Gluten hypersensitivity and autoimmune condition. Why? Because your CD4 cells and immunoglobulin A are mediating the whole damage. There you have you have the whole thing happening inside your small intestine, and we'll be looking at it in a while, what happens in our small intestine. But if I were to look at our digestive system or our whole intestinal tract, we start from the mouth and it ends at your anus, right? But throughout this, there are a few parts that deal with the absorption. And I mean, you all are definitely going to agree with me that small intestine is the part of your intestinal tract where most of the absorption occurs. And if there is any pathology that is affecting your small intestine, like I said, your duodenum and jejunum get affected mostly. Definitely you're gonna have problems in absorbing nutrients, hence you get malabsorption. So before we move on to the pathophysiology, let's just talk about the risk factors. I mean, what people are at risk of developing celiac disease, right? So always remember, whenever you have a condition that is autoimmune in nature, I mean autoimmune, right? Like it's just written right here. A condition that is autoimmune in nature, it's definitely going to have an association with other autoimmune diseases as well. So what common autoimmune diseases do we have? I mean, the first one is type 1 diabetes, juvenile diabetes or early onset diabetes. It's autoimmune in condition. So autoimmune diseases, they have a correlation. So the risk factors are people who already have type 1 diabetes are at risk of developing celiac disease. Secondly, Hashimoto thyroiditis. It's a condition regarding your thyroid in which you have initially hyperthyroidism and then hypothyroidism. So Hashimoto thyroiditis is also autoimmune in nature. So since it's autoimmune in nature and So someone who has Hashimoto thyroiditis will be at increased risk of developing celiac disease. Thirdly, myasthenia gravis is also autoimmune in nature. So people with myasthenia gravis are going to be prone of developing celiac disease. So just remember, autoimmune conditions have a correlation. You have one, you might end up getting the others as well. So I'll just list them down here for you guys. So the first condition that we discussed was type 1 diabetes. Here, type 1 diabetes mellitus. Second, we discussed Hashimoto thyroiditis. And the third that we discussed was myasthenia gravis. Now, if you guys notice, the one thing that we have common in these three is they're all autoimmune in nature. So just concluding the point that one autoimmune disease has a relation with the other as well. So if you have any of these, you can end up getting celiac disease. So now let's see where the magic happens. I mean, no pun intended, but this is our small intestine, right? So we talked about gluten hypersensitivity. So let's just see what happens to gluten. Gluten is present in wheat, you have gluten in barley, you have gluten in oat. So anyone consuming wheat, barley or oat, they're indirectly taking gluten, right? So someone who is prone to developing celiac disease or is going to develop celiac disease, let's see what happens to gluten in their body. So gluten is going to go to their small intestine, where it's going to get broken into gliadin. Gluten gets broken to gliadin. Now gliadin is basically the pathognomonic material that mediates the whole damage. I mean, that is that one naughty particle that is mediating this whole thing. So indirectly it's gluten, but the pathognomonic material is gliadin. Gliadin is going to enter, this is our lumen, this is our intestinal wall. I mean, this is the brush border. You have these epithelial cells in the intestine, and you have numerous villi in on them. So gliadin is going to come inside. Now this is what we're gonna see in a patient who has celiac disease. This isn't the normal patient, this is someone who has celiac disease. So gliadin is going to come here. I'm gonna write gliadin over here. So yeah, this is gliadin. Gliadin came inside your brush border cells, and we have gliadin here. Now what's gliadin going to do is it's going to make these epithelial cells release IL-15, interleukin 15. And what is going to release that? These epithelial cells, these intestinal cells are going to release IL-15, interleukin 15. So we have interleukin 15 here, interleukin 15. Now what interleukin 15 does is it's going to make your intestinal cells produce CD8 cells. CD8 cells are basically your killer cells, killer T lymphocytes. So IL-15 is going to allow for the production of CD8 cells. Now CD8 cells, these are your CD8 cells over here. These are your CD8 cells, and these CD8 cells will have two things on them. They will have a natural killer cell marker, that is your NKG2D, and it's going to have a receptor for MICA. Now what is MICA? MICA is basically a type of MHC protein, major histocompatibility protein, and we'll see how is this all relatable. Now due to gliadin, all of this stress is happening. You have these T lymphocytes that are being proliferating. IL-15 is being released by your intestinal cells and proliferating the whole thing. So this is basically your stress, right? This stress is going to allow these intestinal cells to express what? MICA. I mean, you have MICA receptor on your T killer cells, that is your CD8 lymphocytes. You have MICA's receptor on them, but your intestinal cells are going to express what? MICA. They are going to express MICA. Yeah, MICA, and MICA is basically a type of major histocompatibility protein, MHC. Now, these T lymphocytes, since they have a receptor for MICA, what are they going to do? They're going to go and attack your intestinal cells using the MICA protein. Now, as the name suggests, I mean CD8 killer T cells. Like if they're killer cells, I mean the name suggests that they are going to damage the whole intestinal, cells that are lining your alimentary canal. So if they damage your intestinal cells, what's going to happen? I mean the whole barrier is just going to vanish, and for gliadin to come inside, there's not going to be a barrier left. So not just one particle, but all of gliadin is easily going to come down here because your intestinal cells have been damaged by CD8 lymphocytes due to MICA's expression, and having MICA receptor, they just bind to your intestinal cells and they damage your intestinal tract. So now you have a lot of gliadin coming inside because you don't have a barrier left. I mean, it's all damaged. Now what's going to happen? Initially, what did we discuss? This is the whole immune mediated damage is due to CD4 cells and IgA. But up till now we haven't discussed CD4 cells, and we're going to discuss them right now. So these are your antigen presenting cells, these are your CD4 cells, and these are your B cells. So we have APCs here. This is going to be your CD4 cell, and these are your B cells. Now gliadin came, the whole thing has been damaged, gliadin comes in easily. What is going to happen? Gliadin is going to bind to your antigen presenting cells, and your APC cells are going to have what? HLA DQ2 and DQ8. I mentioned that HLA DQ2 and DQ8 is what increases your risk of developing celiac disease. So your APC cells are going to have HLA DQ2 and DQ8 on them, which is why your APC cells are going to bind to gliadin and they're going to present gliadin to your CD4 cells. I mean APC, antigen presenting cells, so they are going to present, right? So they're going to present gliadin to CD4 cells that are your T helpers cells. After this, after they have presented it to CD4 cells, CD4 cells are going to mediate the damage. They're going to mediate a damage, they're going to initiate an immune response against gliadin and damage your whole intestinal wall, and it's also going to signal B cells to produce antibodies. I mean, what's the function of B cells? B cells make your antibodies, right? They make immunoglobulins. So CD4 cells are going to signal B cells to make antibodies, and those antibodies are of significant importance, and we're going to be discussing them in the investigation section. So this was the whole damage. I'll just repeat it again quickly so that I know that all of you are on track. What happened was that you had gliadin. I mean, gliadin came from gluten. Gluten was broken down to gliadin. And one more thing, gliadin gets deamidated by tissue transglutaminase. It's an enzyme that deamidates gliadin to deamidated gliadin. And tissue transglutaminase again has a significant importance. We'll be discussing that in the investigations box. So gliadin came inside. Gliadin made the intestinal cells to produce what? Interleukin 15. Interleukin 15 caused the intestinal cells to proliferate. It allowed for the proliferation of CD8 cells that are your killer T cells. Those CD8 cells had two things on them. They had a natural killer cell marker and NKG2D, and it had MICA receptor on it. MICA is basically a MHC protein, and your intestinal cells are going to have MICA on them. These killer T cells having the receptor of MICA is going to bind to your intestinal cells and damage your intestinal lining, making no obstruction for gliadin to come in. More of gliadin is going to come inside. Your APC cells having HLA DQ2 and DQ8 on them are going to present gliadin to CD4 cells. CD4 cells are going to mediate a damage against it, and it is going to request B cells to produce antibodies, and those antibodies we'll be discussing shortly. I hope this whole pathophysiology is clear. Now, since we have discussed all of this, and I mentioned in the introduction that small intestine is the part of your alimentary canal where you absorb literally everything. That is where you absorb most of everything. Now, since we aren't basically absorbing a lot of stuff and we have malabsorption, so what's going to happen? I mean, let's just look at those nutrients that you absorb. You have iron, you have B9, you have calcium. B9 is basically vitamin B9. You have calcium, you have magnesium. So you won't be absorbing iron since your villi are damaged. I mean, this is going to damage your villi. No Fe for you. If you don't have Fe, you're definitely going to end up with iron deficiency anemia. If you don't have B9 inside your body, what are you going to end up with? Megaloblastic anemia, right? Megaloblastic anemia, you have B12 deficiency and B9 deficiency. So you won't be able to absorb B9 or B12. You won't be able to absorb iron. You won't be able to absorb calcium. You won't be able to absorb magnesium. I mean, you won't be able to absorb a lot of macro and micronutrients, which are going to result in iron deficiency anemia, megaloblastic anemia. You obviously calcium is important for your bones. So you will have deficiencies inside your body. So let's see what are going to be your signs and symptoms. I mean, let's just focus on the intestine first. I mean, intestine specific signs and symptoms. So the first thing that you're going to have is you will have diarrhea. I mean, obviously diarrhea will be there, and it's going to be chronic because you have malabsorption. When you can't absorb, when you can't make feces properly, you're just going to end up with diarrhea. Secondly, what are you going to have? You're going to have bloating. Now, what is bloating? Bloating is basically production of gas that leads to abdominal distension. So this is something that a person will have. I mean, they'll have a distended abdomen and they're going to complain of gas. Thirdly, they're going to have iron deficiency anemia. They're going to have megaloblastic anemia. And if they have B12 deficiency, they will have numbness, tingling that they'll feel inside their body, and they're going to complain to you of that. So I'll just mention that here. Iron deficiency anemia, megaloblastic anemia, short for MA, numbness and tingling. And there are a few things that you notice in that patient. The first thing, due to malabsorption, the patient will have weight loss. They're going to complain to you of weight loss, and weight loss is simple. You're not absorbing. You are eating everything, but you're not absorbing. And if you're not absorbing, your body isn't extracting anything out of the food that you're taking, you're definitely going to have weight loss. Apart from that, these people will have short stature. I mean, if they're in their growing age and they have celiac disease, they're going to have a short stature because obviously their growth is going to be reduced compared to someone who does not have celiac disease, who does not have any pathology involving absorption of nutrients inside their intestine. So growth stature is going to be reduced. Secondly, if these are children, they're going to have delayed puberty. Their puberty is going to be delayed. So delayed puberty, short stature. Apart from that, if they're children, so children are going to have diarrhea, and they just might not be able to thrive at all. So failure to thrive in children who are really young. Apart from that, grow short stature and delayed puberty. So delayed puberty and short stature. Now, there is this one thing that you will have in that patient, and that is dermatitis herpetiformis. Now, what is dermatitis herpetiformis? It's basically a papulovesicular rash that you will have on your extensor surfaces, that are going to be your buttocks, your forearm, basically your elbows, on your extensor surfaces basically. And since it's a papulovesicular rash that you also have when you have the herpes infection. When you have herpes simplex infection, you have papulovesicular rash. And in people who have celiac disease, you also have a similar rash like herpes, which is why we call it dermatitis herpetiformis. And why does that happen? It happens because I mentioned earlier that the whole thing is mediated by CD4 cells and IgA. So that particular IgA is going to get deposited inside your dermis, and it will give you a papulovesicular rash that looks like just the same rash that happens in herpes, and you call it dermatitis herpetiformis. So these are going to be your signs and symptoms that the patient is going to have: diarrhea, bloating, iron deficiency anemia, megaloblastic anemia, numbness, tingling, short stature, delayed puberty. All of these signs and symptoms are going to be there inside in your patient because they have difficulty in absorbing. Now, coming on to the investigations, I mean, how are you going to investigate that a patient has celiac disease? So if you guys remember, when we were talking about all of this, I said that B cells are going to produce antibodies that we'll be seeing in the investigations box. So let's look at those antibodies. So the first antibody, that is basically your initial test. I mean, when we talk about medicine or when we talk about your clinicals, there are two things. You have a best initial test and then you have a best confirmatory test. So your best initial test is going to be your antibodies. Best initial is going to be the antibody against tissue transglutaminase. Antibodies against tissue transglutaminase. So what does tissue transglutaminase do? I just mentioned this earlier, that gluten is broken down into gliadin, and then gliadin is deamidated by tissue transglutaminase. So your B cells are going to produce antibodies against your tissue transglutaminase, and they're going to be there inside the patient's blood. So the best initial test is going to be to detect for antibodies against tissue transglutaminase. Now, but one thing you need to make sure of, one thing, that is the patient shouldn't be deficient in IgA. I mean, we talked that the whole immune mediated damage was being done by CD4 cells and IgA, right? So you need to see, because there are a lot of people who have IgA deficiency. So before you do any of the investigations, one thing that you need to make sure is you order a test in which you see and assess the patient's IgA levels. If the IgA levels are deficient, that means that the patient has IgA deficiency, and you will have to look for IgG immunoglobulins, because then the whole immune damage is going to be mediated by IgG immunoglobulin if the patient is IgA deficient. If they aren't IgA deficient, then you just have to look for IgA antibodies, and you can easily see if the patient is deficient or not by ordering a IgA test to see their normal levels. So coming back to the point, once you have seen that the patient isn't deficient in IgA, you will do the best initial test, that is see for antibodies against tissue transglutaminase. Once you did that and you did get a positive finding, there are positive antibodies against tissue transglutaminase in the patient's blood, then you need to confirm your diagnosis. After the best initial test, you need to do a confirmatory test to confirm the diagnosis, and the confirmatory test can be done by two methods. You have two things to confirm. You can choose either. The first one is biopsy. Do a endoscopic biopsy in which you insert an endoscope, you go down, and through that endoscope you visualize everything and also take a sample out and biopsy it to see any of these damages that might be present in your small intestine. So endoscopic biopsy. Now, when you biopsy a sample, so what are you going to see? I mean, in a patient that has celiac disease, so you will be seeing a few things that are going to be there in the small intestine. The first thing is you will have a high number of CD8 cells. You will be able to visualize. You will be able to see intraepithelial CD8 cells that will be very high in number and will be clearly present in the tissue sample. That is going to be your first thing, high levels of CD8 cells. Secondly, what will you see? You won't see any villus. I mean, you will have villus atrophy in a patient with celiac disease. Why? Because these CD8 cells are going to damage your villi. They're completely going to be atrophied. So villus atrophy. First thing, high levels of CD8 cells. Second thing, villus atrophy. The third thing that you will see in that patient is crypt hyperplasia. What is crypt hyperplasia? If I were to draw two villi, I mean, let's say this is one villi and this is the second villi. So this part, I mean the space between the two villi, this is your crypt. So in a patient of celiac disease, you will have villus atrophy. That is, your villi are going to like disappear. Like, I mean, they won't be increasing your surface area. They'll just be like this villus atrophy, blunting of your villi. And this crypt, you will have crypt hyperplasia here. So this is going to be like, completely regenerated tissue with crypt hyperplasia. So this is very important to understand. Crypt hyperplasia, villus atrophy, and high levels of CD8 cells. So this is what you're going to see in the endoscopic biopsy, and this is going to be a confirmatory test. But let's say the patient did not agree. They didn't want to do endoscopic biopsy. They were just too scared. I mean, this can happen in young people as well. So in that case, what you can do is you also can go for an other antibody test, that is antibodies against your endomysium. Antibodies against your endomysium. In patients with celiac disease, you might have these. So if you have positive finding for antibodies against your tissue transglutaminase, you test for endomysial antibodies. If they're positive as well, confirm that the patient has celiac disease. You do tissue transglutaminase antibodies and you do a endoscopic biopsy where you see villus atrophy, high levels of CD8 cells, and you see like crypt hyperplasia. Confirmed diagnosis that the patient has celiac disease. So basically, like, what did we talk about? We talked about, like, the facts that are there in celiac disease, the risk factors, the pathophysiology, signs and symptoms, and investigations. So we're out of boxes. Where do I write the management? I mean, well, let's just think out of the box. So what do you think could be the management? It's very simple. I mean, the whole disease is complicated, but the management is very simple. Gluten-free diet. There you go. You have a patient with celiac disease. The first thing that you do, put them on a gluten-free diet, and their problem is going to resolve. I mean, obviously, the whole thing is due to gluten hypersensitivity. Remove gluten from their diet, they're not going to have anything, and celiac disease won't progress further. They might not come to you with any of these signs and symptoms that they have things happening inside their body. But obviously, there are some conditions in which even if you put them on a gluten-free diet, they don't resolve. So how can you treat them then? What did I say? This is a autoimmune condition, and in an autoimmune condition, what do you do? I mean, how do you treat those conditions? You need to suppress their immune system. Their immune system is acting against the body. Suppress their immune system, they're gonna be fine. So put them on steroids or put them on immunosuppressants, and they'll be fine. One thing to remember, patients who are on gluten-free diet, they need to avoid everything that has gluten, but they can start one thing. They can start taking oat after 6 or 12 months of the gluten-free diet. I mean, they have to stay on gluten-free diet, but if it has been 6 or 12 months, then you can start them on oat only. Just oat, nothing more. So I mean, patients who want to eat oat, they can be on a gluten-free diet and yet eat oat after 6 to 12 months. And one thing to remember, patients with celiac disease have this one particular complication in which they can develop a T-cell lymphoma in them of the intestine. Now, how can they develop T-cell lymphoma? Do you see this IL-15 over here, yeah, here, this IL-15, high amounts of IL-15 can lead to proliferation of CD8 cells, right? I mean, that is what we discussed. But uncontrolled levels of IL-15 will produce what? They're going to lead to proliferation of CD8 cells a lot. I mean, a lot of cells are going to proliferate, and these CD8 cells, after mediating celiac disease, have a tendency of developing into T-cell lymphoma. Because T-cell lymphoma has high amounts of CD8 cells, and where do these CD8 cells come from? IL-15. So high amounts of IL-15, high amounts of CD8 cells. Celiac disease complication is T-cell lymphoma. So patients, if they don't control their diet, if they don't take care of themselves, patients of celiac disease can develop T-cell lymphoma as a complication. So guys, with this, we come towards the end of the session. We talked about everything, the pathology, investigation, the treatment. That is pretty simple, gluten-free diet. So I hope there are no questions. If there are any questions, feel free to write them down in the comment section or reach out to us on our Facebook page. And with that, thank you so much for watching. Stay tuned and keep watching Excemy Medical.